All right, welcome to this session. People will be filing in for sure, but hope you enjoyed the break. I hope you guys get a chance to visit the vendors. They spend a lot of time, so please go by and look at the vendors. If you're scoring today, if you're part of the program committee or the board, please remember to score the abstracts in this session today, because many of them are eligible for awards. So I'm Kathy Van Leeuwen, the Associate Surgeon-in-Chief in Phoenix and co-director of a fetal center where we don't do interventions. So we only do care coordination. So you can all come up to me later and pitch that we should send the patients from Phoenix to your centers. I would love to hear those pitches. And I'm joined by Marissa Schwab, who's finishing up her pediatric surgery fellowship in Stanford and then staying on staff at Stanford. So yay, Marissa. So our first presenter today is Michael Phillips. So if we can invite Dr. Phillips up to the podium. And he's presenting on medical and economic burden of care for congenital anomalies, a report from the Child Health Evaluation of Surgical Services Group, the CHESS Group.
I want to thank APSA for allowing us to present our work on surgically correctable congenital anomalies. See if I can get this to advance. We have no disclosures.
Can you guys hear Dr. Phillips?
Can you hear me? Is the microphone working? Too tall?
Thanks, Peter.
Okay. There's increased focus on patient-reported outcomes and patient-centered outcomes in the development of shared decision-making treatment algorithms. One area where more data are needed is in the treatment of surgically correctable congenital anomalies. We've demonstrated improved clinical outcomes, but these require comprehensive, coordinated care and short and long-term follow-up after their index hospitalization. We hypothesized that common surgically correctable congenital anomalies would have significant variability in the days spent in medical therapy during their first year of life and differential financial burdens impacting patients and their families. We sought to characterize that using the MarketScan Medicaid database and used the years 2009 to 2021 and included children who were continuously enrolled from birth to 1 year of life with the following congenital anomalies: congenital diaphragmatic hernia, esophageal atresia and tracheoesophageal fistula, intestinal atresia, Hirschsprung's, anorectal malformations, gastroschisis and omphalocele, and patients with multiple congenital anomalies were excluded. We then characterized the medicalized days, or the days spent in medical care, across inpatient, outpatient, ED, and non-ED outpatient visits, which consisted of radiology visits, pharmacy visits, endoscopy, and other interventions. To stratify patients by the severity of their comorbidities, we use the Pediatric Complex Chronic Condition Classification System, which groups ICD-10 diagnosis codes across 10 body systems to determine the sort of severity of their illness. And then technology dependence is another variable included in the database, which is a yes-no variable for implanted or invasive devices responsible for sustaining life, like a tracheostomy or gastrostomy tube. To estimate the wages lost per medical day or the financial burden of caring for children with congenital anomalies, we use the median household income from 2023, divided that by the average number of days spent working, 270, for an average financial loss of about $300 per day spent in providing medical care, and then multiplied that by the mean number of medicalized days. We did descriptive statistics and multivariable regression analysis. Our descriptive statistics across the anomalies were similar for sex, race, and ethnicity to differences described in other studies on the individual anomalies, and the distribution of complex chronic conditions and tech dependence were also similar to what we expected to find as well. When we looked at the number of patients in each category, we found between 2,000 and 8,000 patients in each of the categorized anomalies. When we looked at the mean number of medicalized days, it varied greatly across the specific anomalies, with the fewest number of days being for patients with gastroschisis and omphalocele at 32, and the highest number of days on average being among congenital diaphragmatic hernia and esophageal atresia. There was also variability in how those days were spent. So our patients with Hirschsprung's had the shortest index hospitalization, around 9 days, and the longest index hospitalization was intestinal atresia patients with around 26 days, with variability in their outpatient follow-up needs as well. when we estimated the financial impacts of this medicalization, we found differential impacts as well, with gastroschisis and omphalocele around $9,600 and esophageal atresia around $22,000. On multivariable regression analysis, the type of anomaly was predictive of an increased rate of medicalized days, with gastroschisis and omphalocele being the referent and all the others having a higher rate of medicalization. When we looked at race and ethnicity, there was a increase in the rate of medicalized days for non-Black children. And when we looked at complex chronic conditions and tech dependence, 3+ chronic conditions and tech dependence were both associated with an increased number of medicalized days, while one complex chronic condition was actually protective against medicalization. And so what we found was that for surgically correctable congenital anomalies, there was a different number of mean medicalized days, with gastroschisis having the fewest and CDH and esophageal atresia having the most. After controlling for pertinent covariates, the type of surgically correctable congenital anomaly, non-Black race, 3+ complex chronic conditions, and tech dependence were all associated with an increased number of medicalized days, while only one complex chronic condition seemed to be protective. There was variation in the medicalized days, leading to a range of estimated financial loss between $9,600 and $22,000, which, based on the median income, represents between 12 and 28% of the median income. And this is the first population level study to examine medicalized days and financial impact of caring for children with complex congenital anomalies and comparing them between types. There are a lot of limitations to this study. It is an administrative data set, and we realize that. That leads to a lack of granularity and an inability to audit the data. It also may bias our results against children who are lost to follow-up. But MarketScan is a validated data set, and it's been used in multiple studies, and we think that it's reliable in its reproducibility. We also note that the estimates of financial burden are only estimated based on median income, and so disparate impacts may be felt for different family structures and income levels. But we do feel like, in spite of these limitations, this provides us concrete data to guide prenatal counseling and postnatal care for these children, with hopefully assistance in policy creation to protect families and children who have congenital anomalies in a data-driven way. I'm happy to answer any questions.
Well, I just want to thank you, congratulate you for doing this work. There we go. There was a paper recently presented at the American Surgical that indicated in the post-abortion law era in Texas that the incidence of congenital anomalies in that time period was 16%, which was staggering, and that was on a continuous increasing curve. So the question becomes, if we imagine a future, if there were to be a complete ban, and Tippy McKenzie's work hasn't caught up yet to prevent all of these, what would be the financial impact, can you imagine, if we had a society where 20% of all children born had some kind of congenital anomaly?
I think that's a great question, and certainly an important policy implication. I think additionally, I don't think we, at least when we counsel patients before and after delivery, always appreciate just how burdensome this can be on them. And when we don't arrange sort of consistent follow-up or follow-up with multiple providers on the same day, it just really, I think this quantifies just how impactful that is when we have them come back for an x-ray and then see us another day, or see us and then see urology the following week. It really, I think, can be devastating. And so I think hopefully this changes, sort of helps guide policy discussions, but also our approach to the patients that are in front of us and trying to coordinate care as much as we can to make their lives a little bit easier.
Thank you, Dr. Phillips.
Thanks.
Thank you. Our next speaker is Dr. Pollack, presenting prenatal esophageal lengthening by distraction enterogenesis in a fetal lamb model of lung gap esophageal atresia.
I'm not quite as tall. Thank you for the opportunity to speak today. I will be talking about prenatal esophageal lengthening in a fetal lamb model of long gap esophageal atresia. I have no disclosures. Distraction enterogenesis is a surgical technique used to lengthen the intestine by applying mechanical force, typically through an intraluminal device like a spring. This method has been extensively studied in the context of short bowel syndrome. Long gap esophageal atresia is also a disease of foreshortened intestine. Current methods of lengthening delay primary repair for weeks to months after birth, and they require alternative methods of feeding, ventilation, and paralysis during that time. A prenatal therapy has the potential to allow primary repair in the first days of life, similar to patients with short gap esophageal atresia. Given this, we created a fetal lamb model to study distraction enterogenesis as a method of prenatal esophageal lengthening. 6 fetal lambs underwent esophageal atresia defect creation during late gestation. Compressed nitinol springs encased in a gelatin capsule were placed in the proximal pouch of 4 animals, and non-expanding springs were placed in 2 animals to serve as controls. Fetuses were returned to the uterus to continue gestation until delivery via cesarean section and necropsy near term. Pregnant ewes underwent midline laparotomy and hysterotomy with partial delivery of the fetus. Fetal lambs underwent right posterolateral thoracotomy and identification of the intrathoracic esophagus. The esophagus was ligated near the diaphragm, and the distal portion of esophagus from the diaphragm to the mid-thorax was resected and collected as control tissue. The spring was placed in the remaining proximal esophagus. A plication suture was placed proximal to the spring, and the esophagus was suture ligated distal to the spring. The distance between the 2 sutures was measured. Following the procedure, the fetus was returned to the uterus to continue gestation. All animals survived to necropsy without complication. The length between the plication suture and the end of the proximal pouch was measured at the time of creation and again at necropsy. The length of the proximal pouch increased by 6 to 10 millimeters in the experimental group. No lengthening was achieved in the control group. At the time of necropsy, tissue was collected from the pouch that contained the spring, as well as from the portion of esophagus proximal to the plication suture. Histologic analysis showed maintained tissue architecture. Trichrome staining was performed with collagen stained in blue to evaluate the degree of fibrosis following distraction enterogenesis. Quantification of the trichrome staining showed increased collagen deposition or mild fibrosis in the lengthened pouch compared to control, while the area proximal to the lengthened pouch showed no difference compared to control. In conclusion, we have achieved prenatal esophageal lengthening in the fetal lamb via distraction enterogenesis. This method is well tolerated and is a promising fetal therapy for long gap esophageal atresia. Future studies will focus on miniaturization of the spring to enable fetoscopic endoluminal device placement, as well as alternative methods of anchoring the spring within the esophageal pouch. I'd like to thank my incredible collaborators at CHOP and Stanford. Thank you for your attention. I'm happy to take any questions.
You answered my first question about whether you would consider fetoscopic placement down the road, but what about the plication sutures? How would you place those?
Yeah, so that's something that we've thought a lot about, and we don't have a solution yet, but some of the things we've thought about are potentially some sort of submucosal injection that would absorb over time, as well as potentially some sort of barb mechanism on the outside of the spring that would keep it in place.
Good on time?
Yep, perfect.
Ronnie Marwan from the University of Missouri. Congrats, this is really fascinating, elegant design and very well presented. My question is, the premise of a fetal intervention requires that you make the diagnosis, and the diagnosis of esophageal atresia now, even with fetal MRI, is not really consistent. So how do you envision translation to clinic? And is this really the proof of principle to do it in the fetuses, but you're gonna say we're gonna do this in neonates rather than fetal intervention?
That's a great question. I do think that realistically, this would likely be an intervention that occurs postnatally first. I think further down the line, it's kind of a dream that this would happen prenatally. I think in terms of the prenatal diagnosis, we are currently looking at our data at CHOP in conjunction with our fetal radiologists to get a better idea of how reliably we can tell whether it's long gap or short gap disease.
Thank you very much. Our next presenter is Dr. Alex Huang from Boston Children's Hospital, one of the research fellows. Will be presenting transamniotic fetal delivery of recombinant human immunoglobulin monoclonal antibodies, a potential novel strategy for prevention of neonatal respiratory syncytial virus disease.
Good afternoon, everyone. Thank you for the opportunity to present our work. We have no disclosures. We were motivated to perform this research by our interest in determining whether a clinically relevant monoclonal antibody could be delivered to the fetus and the neonate via transamniotic fetal immunotherapy, or TRAFIT. Its importance is related to the need for novel strategies for the prevention and/or treatment for respiratory syncytial virus disease, or RSV, which still presents a major health burden, particularly in neonates. TRAFIT is one of 3 forms of therapies that have been developed in our lab to deliver fetal therapies, which involves transfer of a given agent that's injected into the amniotic fluid to the fetal circulation via likely placental routing after uptake through the amnioplacental interface. Immunoglobulins of the G class are normally transferred from the mother to the fetus via FcRn receptors in the syncytial trophoblast. It is believed currently that this mechanism also plays a role in the transfer from the placental to the fetal circulation, whereby IgG crosses the gestational membranes from the fluid to the placenta. The TRAFIT approach allows for minimal maternal exposure to injected antibodies, as well as the delivery of immunoglobulins that normally do not cross the placenta, such as IgA. Various potential applications of TRAFIT have been demonstrated experimentally and continue to be developed in our lab. RSV is one of the infections for which TRAFIT could conceivably be beneficial in a clinical setting. It is an exceedingly prevalent disease, infecting approximately 90% of children within the first 2 years of life, and it is associated with a major burden on infants and neonates. It also tends to be more morbid in patients who are under 6 months old, as well as those who have genetic or other congenital diseases. Of particular note, RSV can be transmitted vertically during pregnancy, both before and after birth, in which case it is not uncommon for the neonate to require intensive care immediately upon delivery. Select monoclonal antibodies have proven to be protective against RSV. These types of antibodies are commonly engineered to have specific targeted effects with a growing variety of therapeutic applications today. They're typically based off of IgG antibody structures and are able to undergo modifications via recombinant technology that are able to confer additional characteristics such as extended half-lives. Nirsevimab is a relatively new iteration of recombinant monoclonal antibodies against RSV that features a modified Fc chain conferring additional stability. It has demonstrated increased antigen binding when compared to palivizumab, which is a previous iteration of monoclonal antibody against RSV. And in fact, current CDC guidelines recommend nirsevimab administration for all infants entering their first RSV season. Thus, in this study, we sought to determine whether transamniotic delivery of a nirsevimab equivalent monoclonal antibody could be a viable strategy for passive protection against RSV and remain bioavailable after birth. In our experiment, time-stated dams received volume-matched intraamniotic injections of either the antibody or normal saline to control for interspecies homology of the immunoglobulin. 75 fetuses in total were injected on day 17 of gestation, and serum and lung samples were procured at term, which is gestational day 21, as well as postnatal day 7 for a nirsevimab-specific ELISA analysis. Overall, there were no significant differences in survival across the groups. However, separate analyses at each time point did show significantly higher survival in the experimental group at term, with no significant difference at the postnatal time point. Serum levels of nirsevimab were significantly higher at both term and postnatal time points in the experimental group. The presence of positive, albeit weak, signal in our controls does suggest some native homology with rat immunoglobulins, but serum levels in mothers of all groups were very low, and there was no significant difference in the exposed versus unexposed groups. Similarly, nirsevimab levels in the lungs were also significantly elevated, both at term and on the postnatal day 7 in the experimental group. In conclusion, traffic with a clinically relevant monoclonal antibody against RSV leads to sustained levels of the antibody in the serum and lungs of the neonate at term and into the early neonatal period in a rodent model. These results suggest that traffic could become a viable novel strategy for a very early passive prophylaxis against RSV in select clinical scenarios, including changing endemic patterns or a late diagnosis of congenital or genetic diseases. I want to thank all my co-authors, my PI, Dr. Falza, our sources of support, and to you for your attention. And I'm happy to take any questions at this time.
Questions? So I have one question for you. So you've shown that you can deliver the antibody and overall the outcomes are better. How would you, if that translates to a human model, how would you track the infants where it was successful? Would you watch them to make sure they don't get RSV? Would you study their exposure? How would you track the success rate?
Mm-hmm. The data about how serum levels of nirsevimab correlate to outcomes is probably still to come. This is a very, very new iteration of this drug, and probably with these new recommendations, we'll get better data of what serum levels correlate to a certain degree of protection. And I would assume that would be a good way to, on a population level, examine whether or not our patients have sustained levels of the antibody postnatally in this very early period before they can actually get their first doses, especially mothers who don't have the maternal vaccine given. They may not have any other options for protection.
All right, thank you very much.
Dr. Seskleifer will be presenting variation in the prenatal diagnostic evaluation of lung malformations among fetal care centers in the United States.
Good afternoon. Thank you for the opportunity to present. We have no disclosures. There are currently no prenatal imaging guidelines for congenital lung malformations, and it's unclear how centers are currently using prenatal imaging to evaluate these lesions. With an increase in prenatal diagnosis for CLMs, understanding current practice patterns and establishing fetal imaging guidelines will be critical to ensure appropriate prenatal care and reduce unnecessary tests. Congenital lung malformations occur with an incidence of 1 in every 2,000 live births. Prenatal diagnoses have risen threefold in the past 30 years, which researchers attribute to improvements in ultrasound resolution and operator experience. However, there remains a lack of consensus on fetal imaging guidelines. Our aim in this study was to examine variation in the utilization of various prenatal imaging modalities during the diagnostic workup of CLMs. To study this, we analyzed data from the newly formed Congenital Lung Malformation Study Group database. This database is a national representation of 17 fetal centers across the country. In this talk, I will be presenting slightly updated data, which now includes data from 1,536 patients across 17 centers between the years of 2016 to 2023. The majority of patients that we had were diagnosed prenatally by fetal ultrasound at a mean gestational age of 22 weeks, and the most common diagnosis was CPAM, followed by BPS. A CPAM volume ratio, or CVR, was noted in just over 70% of fetuses, and patients underwent an average of 3 to 4 CVR measurements during their pregnancies. The mean initial CVR was 0.65 at 23 weeks, and the mean maximum CVR value was 0.88 at 27 weeks. CVR use varied by center. In the graph on the left, you can see the percentage of prenatally diagnosed patients who have at least one documented CVR measurement graphed by institution. On the right, you can see the average number of CVRs per patient, with institutions presented in the same order for easier comparison. As you can see, both the percentage of patients receiving a CVR measurement and the frequency of CVR measurements varied greatly by center. In this graph, the x-axis lists the maximum CVR value for a patient, and the y-axis lists the number of CVR measurements that the patient received. There was no correlation between maximum CVR value and the number of CVR measurements. Likewise, fetal echocardiogram use varied by center. Overall, 51.8% of patients received at least one fetal echocardiogram, with institutional use ranging from a high of 87% to a low of 7%. Fetal echocardiogram use was correlated with ultrasound findings, including high drops mediastinal shift in the presence of a cardiac anomaly. And finally, we found that fetal MRI use also varies quite widely by center. Some centers get at least one MRI in nearly every patient, and other centers use MRIs quite sparingly. fMRIs were more common among patients who had larger lesions, as reflected by both the initial and the maximum CVR values. Patients were significantly more likely to undergo a fetal MRI if mediastinal shift was noted on ultrasound imaging, but there was no difference in patients with signs of high drops. Patients with a prenatal diagnosis of BPS were significantly more likely to undergo a fetal MRI, and patients with a diagnosis of CPAM were significantly less likely to get an MRI. MRI was also more common among fetuses that had other congenital anomalies. MRI use was correlated with perinatal interventions, including steroid administration, fetal thoracentesis, fetal operations, and neonatal resection within the first week of life. Despite the correlation with prenatal interventions, fetal MRI use did not correlate with symptomatology at birth, including respiratory distress, supplemental oxygen, and ventilator use. In an effort to determine the indications for fMRI in our study, we examined MRI reads and found that 42% mentioned the lesion's vascular supply and 28% mentioned the lesion's measurements. Only 8% of reads had fetal lung volumes, and 5% of scans found another fetal anomaly. In conclusion, this large multi-center study suggests substantial variation across institutions in the prenatal evaluation of CLMs based on both CVR and echocardiogram as well as MRIs. Fetal MRIs are potentially helpful in defining the anatomy in patients with large lesions and in the planning of perinatal interventions. However, there was no correlation with postnatal outcomes. Given that study overutilization contributes to additional time and resources and may not have clear outcomes for either the mom or the fetus in this case, these data support the need to collaborate with our maternal fetal medicine colleagues to establish some evidence-based consensus guidelines. I'd like to thank the CLM Study Group Centers for contributing data to this study, and I'd like to invite you to join us as we transition to our prospective branch of this study, which you can do by joining this or by scanning this QR code. Thank you, and I'll take questions.
Sure, you guys have a lot of questions.
Well, in your abstract, I think you noted that prenatal MRI doesn't even correlate very well with prenatal ultrasound or the postnatal CT, and now you're saying that it doesn't really correlate with postnatal symptoms. So who do you think we should get an MRI on?
So it seems like right now it's highly protocolized based on institutions. So I think that certainly for patients who have an unclear diagnosis, an MRI can be more helpful in discerning that diagnosis. Actually here, we can confirm volumetric measurements, plan for fetal intervention, detect other fetal anomalies, obviously have several cons as well. But I think essentially in cases where you think that you're going to do some sort of fetal intervention or that the fetus may require some sort of procedure in the close perinatal period.
Is part of the prospective study going to be a pathway creation with the MFMs?
That would be for Dr. Kunasaki.
Be ideal.
I don't want to commit
John,
to
you
it.
Bring that to us, and you bring that to APSA to launch it here. I like it. Dr. Olatuya.
Olatuya, Columbus. Nice study. I mean, obviously, I think you're tackling a problem that's difficult to solve just by the way you've looked at it. One of the concerns, it's always hard to go after the fact to figure out what you did preemptively, how that correlates with the outcomes. Say, for example, you got an MRI because you're trying to figure out what to do. Well, you may have gotten it and showed you don't need to do anything, but you already got it. So it may not correlate with what actually was done, but it was helpful to help you make that decision. So I think what's probably most important, like I said, is getting folks together to determine when you actually need to get it, for what indications. And I think it goes without saying that there needs to be collaboration between MFMs, surgeons, and a group as to what we're looking for, what we're doing, And again, I reiterate, it should be just called congenital lung malformation, so we don't make a pathologic diagnosis from just a radiological imaging observation. But nice to.
Absolutely. Thank you.
Thank you very much. Our next presenter is Dr. Anna Maria Dumitru from Children's Hospital of Philadelphia, presenting fetal gene editing, the long and short of it.
Sorry. All right, good afternoon. Thank you for this opportunity to present. These are my disclosures for this work. Dr. McKenzie did a beautiful job of introducing the rationale for pursuing fetal gene editing, so I will skip right to a disease model that we're using to apply this to test the hypothesis of possible advantages of fetal gene editing. The disease model that I've been studying is a metabolic liver disease called hereditary tyrosinemia type 1. It's caused by a defect in the final enzyme in the tyrosine catabolism pathway, which I'm showing you here. When we do have an existing pharmacological treatment, it targets the HPD gene upstream in this pathway. So you might wonder why we picked this model. Now, some of the limitations with the current treatment are that it requires twice daily dosing and a diet restricted in certain amino acids. Additionally, even with excellent compliance, some children fail treatment and go on to develop hepatocellular carcinoma. When this happens, their only option is a liver transplant. As such, we have chosen this disease to, sorry, it's not advancing. Okay. We'll go manually. So we have chosen this disease model, and we're trying to design a one-and-done therapy by targeting the HPD gene. So again, the same gene that the current treatment available targets, using an adenine-based editor and a guide RNA packaged in a lipid nanoparticle. So we started by doing this in adult mice, and what we found was we were able to achieve efficient on-target liver editing. This was correlated with a significant survival advantage in these mice because we inject them and then 2 weeks later we take them off of the treatment they otherwise need to survive. Without that treatment, uninjected mice all die within 21 days off of treatment, but our treated mice survived. You can see histologically a decrease in HPD protein expression in the livers of these mice, and this correlates with phenotypic benefits because they have a rescue in liver function. We then went to a fetal mouse model. We injected using Vitelline vein injections fetally, and then after they were born 2 weeks later, we took them off treatment. We were able to reproduce efficient on-target liver editing. This correlated with a significant survival advantage. These mice gained weight off of treatment, and again, correlation with liver function tests, and we saw the same pattern in the histological analysis. Now, a paper recently came out, which was a very elegant study that showed that unfortunately with AAVs and a CRISPR-Cas9 gene editing model in this disease specifically, the mice still go on to develop tumors at 1 year of age. So we've started a long-term study. This is very preliminary data, but the first 2 mice so far that we've kept out to a year after injection with LNP did not have any evidence of liver tumors. They had efficient liver editing and normal liver function at 1 year of life off of treatment. And this is an attempt to show you a little bit of some of the mice that were kept on nitisinone treatment did have what we think are tumors, and we're in the process of evaluating those more histologically, whereas the injected mice grossly looked normal. Now, we've also been able to inject this lipid nanoparticle in a non-human primate model. So we had fetal injections. We did 4 non-human primate fetal injections and harvested at short time points. What we were able to see was efficient on-target liver editing in the fetal model, and this also correlated with a significant reduction in HPD protein levels. Surprisingly, when we tried this in juvenile monkeys, we actually saw much lower liver editing in these compared to the fetal model. One of the other steps that we have been interested in characterizing is whether there's crosstalk between the pregnant dam, and the fetus. So we started looking at cytokine levels in the serum. Thankfully, we were very relieved to find that so far we did not see any evidence of changes in cytokine levels in the injected dams. They maintained normal liver function at short and long time points after injection. We also did not see any obvious changes in cytokine panels in the treated non-human primate fetuses, so that was also excellent news. And they also maintained normal liver function in their serum after injection. So in conclusion, I know I've covered a lot of ground, but we're very excited to report that our strategy has successfully inactivated HPD gene, and using this injection strategy, we can see a correlation with decreased HPD protein levels, which is sufficient to rescue lethality in our diseased mouse model. This strategy also works in the non-human primate model that we have tried, and so far we have not found any evidence of long-term consequences of this strategy in either the pregnant dams or the fetal non-human primate model. And I would be happy to take any questions.
Can you comment on any off-target effects that you've noted in either of your models?
So our collaborators in the Musunuru lab, they published a study with an off-target analysis using a 1-seq approach, and did not find any significant off-targets with the lead guide RNA that we've chosen to do for this study, so that was encouraging.
Chris Tadare in Colorado, very nice. I always like what Bill's lab puts out. My question for you is, why do you think the delivery mechanism or delivery vector makes a difference? You say your LPN delivery mechanism, you didn't see any malignancies, but the AAV vector was seeing malignancies later on. To me, it doesn't make sense why one is it the amount of base editing that's affected by it? Any thoughts about that?
Yeah, that's a great question, and something that we have thought a lot about. I think some of the challenges, so with the viral vector model, potentially there's something related to genome integration or inflammation. With the LNPs, however, so far we haven't seen anything, but it's a very small number, so it's possible that we will end up seeing more of that over time because we have another cohort of about 12 mice that still need to harvest, but I'm hopeful we won't. I think, time will tell.
Great talk, thank you.
Thank you very much.
Dr. Emily Sire is presenting sustained early postnatal humoral and cellular immunity against human cytomegalovirus after transamniotic fetal mRNA vaccination in a rodent model.
Thank you all for making it to this very last scientific session of the day. We are very grateful to have the opportunity to present our work, and I have no disclosures. We did this research to examine the duration of the immune response after transamniotic fetal mRNA vaccination, first in this study against cytomegalovirus, or CMV. Its importance relates to the fact that CMV infection, as many of you know, remains highly prevalent and is still linked to significant perinatal morbidity and mortality worldwide. Perinatal infections remain a chief cause of neonatal morbidity and mortality. Multiple routes of transmission, including the placenta, intrapartum, or infected breast milk, allow a host of pathogens to reach the fetus or neonate. CMV is one of the most common of such pathogens in the US, often leading to permanent disabilities. Infection in the very early neonatal period has a particularly bad prognosis. Post-exposure antiviral treatments or passive immunization have been shown to be of limited benefit to perinatal management. Therefore, prevention of both congenital and early postnatal CMV is imperative, though treatment options are not yet available. mRNA vaccines have been shown experimentally to be more effective than protein-based vaccines, especially when coding for the CMV glycoprotein B envelope antigen depicted here. Last year, here at APSA, we showed that transamniotic fetal mRNA vaccination is a viable strategy for active perinatal immunization, using an mRNA vaccine against CMV in a rodent model. In that study, we showed, interestingly, that glycoprotein B antigen, encoded by the mRNA injected, was actually produced in the placenta, likely after transport of the mRNA through the amnioplacental interface. We also detected the production of antigen-specific antibodies in vaccinated pups up to 14 days of life, which was the last time point in the study. In this study, therefore, we aimed to determine whether the humoral immune response could persist for months into early postnatal life, as well as to examine whether a cellular immune response also develops over time in the same model. A custom-made human CMV glycoprotein B mRNA was commercially obtained. The final sequence consisted of approximately 2,800 nucleotides and included proprietary end sequence optimization to enhance mRNA stability and decrease immunogenicity. To minimize degradation in vivo, the mRNA was encapsulated by a self-assembling lipid and polymer composite known as lipopolyplex, and an excellent encapsulation rate was confirmed on fluorescence assay. After that, 7 pregnant spring dolly dams underwent volume-matched intraamniotic injections in all 82 of their fetuses of the custom encapsulated mRNA on gestational day 17, or E17. At 3 different time points, spanning between 1 and 3 months postnatally, serum levels of antigen-specific IgG antibodies were measured by ELISA, and the T-cell response was measured on spleen lymphocytes. More specifically, spleen lymphocytes were plated and incubated for 5 days with either enriched media or enriched media combined with the mRNA-encoded antigen, followed by quantitative flow cytometry of cell culture supernatants to assess T-cell response. TNF-alpha and IL-6 were measured as markers of the early phase of the immune response, in which these cytokines are produced by antigen-presenting cells to signal naive CD4-positive helper T cells. IFN-gamma, IL-2, and GM-CSF were measured as markers of later stages, characterized by effector and immunomodulatory functions. There was no maternal mortality or premature labor in any group. Overall postnatal survival was 44%, with no significant differences between the groups. Antigen-specific antibodies were present in serum of vaccinated pups at all 3 time points, albeit decreasing significantly from 1 to 3 months. Not shown here, maternal serum samples also showed the presence of antibodies at all 3 time points without significant differences between the groups. Here we have the flow cytometry data, and just to orient you, dotted lines separate non-challenged cells on the left from challenged cells on the right. When compared to non-challenged cells, spleen lymphocytes from vaccinated pups showed significantly increased production of TNF-alpha and IL-6 in response to that antigen-specific challenge at nearly every postnatal time point studied. This same finding was noted for IFN-gamma, IL-2, and GM-CSF. Notably, cytokine production tended to increase with increasing postnatal age for all markers studied. Taken together, these findings suggest a maturing Th1 predominant response to the viral antigen injected. Of course, a limitation of the study is the fact that the rats were not inoculated with the virus. Yet first, we had to determine whether there was an immune response robust enough to warrant such a challenge, which was our main goal in this study. Notwithstanding this, we can conclude that transamniotic fetal mRNA delivery of a human CMV antigen can induce a maturing, adaptive, cell-mediated immune response, while also exhibiting continued antigen-specific immunoglobulin production, extending into the neonatal period in a healthy rat model. Fetal mRNA vaccination via this minimally invasive transamniotic route may become a practical strategy for the prevention of perinatal infections. Thank you very much.
Questions? So I have a question for you. How early do you think this could be delivered in a human model? And then which types of patients do you think would need this therapy? Would you stratify that out, or do you think all patients should get the therapy?
No, those are great questions that we've thought a little bit about. And I would say because this is transamniotic, there's a lot of advantages because it's a minimally invasive route of delivery compared to a lot of other routes of delivery. But again, you are still limited by technical factors. And so we could imagine this potentially being performed as early as your earliest amniocentesis procedure. That being said, at this point, there isn't any viable option out there for prevention of CMV. So even if we can't catch every single fetus at risk, then this is still of significant benefit. And as far as which patients we would select, it was amazing to me when I was researching about this, how many women are actually have had exposure to CMV, like most of the population, and it's just that adults are asymptomatic typically. So you could imagine a scenario where eventually there would be a universal vaccine for this. But of course, we're starting at the very early experimental preclinical stages. And so like most things, we would want to roll this out first in patients that are at highest risk once we've established safety and efficacy. And so that would probably be women who are either immunocompromised or women actually who have younger children under the age of 3. They're at highest risk of contracting CMV. And Prior to them conceiving or early in their pregnancy, you can find out if they're seronegative and they're at risk of seroconverting, which is when you would have the highest risk of impact to the fetus on that initial infection that they have.
Okay, thank you.
Yeah, absolutely. Thank you.
All right, next is Dr. Jennifer Shu. Did I say it right? Oh, sweet. The effect of ex vivo gravid uterine support on umbilical vessel flow velocities and ductus arteriosus patency.
Good afternoon, and thank you for the opportunity to share our work. We did this work to deepen our understanding of the placenta's effect on fetal hemodynamic regulation, and specifically to understand the placental effect on ductus arteriosus patency and umbilical vessel blood flow in an ovine model. This helped us assess the need for prostaglandin administration with a placental preservation model. The work is important to understand the role of the placenta in blood flow regulation. In the fetal lamb, as in the fetal human, the patency of fetal circulation is paramount to fetal survival prior to exposure to an air environment. Patency of the ductus arteriosus, or DA, is maintained by a complex interplay of biochemical and physiologic factors. The most important factors in maintaining in utero patency of the DA include low oxygen tension, high levels of prostaglandins, nitric oxide, and carbon monoxide. Prostaglandins play a dominant role to oppose constriction and are produced by both the ductal wall, muscle, and by the placenta. PGE2 is the most potent prostaglandin, while PGI2 is the most prevalent. After birth, closure occurs first functionally, followed by anatomic remodeling. One significant factor in the functional closure is the clamping of the cord, reducing the circulating levels of placentally produced PGE2. For this reason, described artificial placenta and womb models without the placenta rely on continuous prostaglandin infusion to maintain ductal patency. Possible side effects include dysrhythmias, edema, and hypotension. Preserving the placenta may temper these effects by maintaining the placental barrier between the circuit and the fetus, favoring physiologic factors that favor the other determinants of ductal patency as well. We aim to investigate fetal ductus arteriosus patency in an ex vivo sheep model of gravid uterine support and to quantify placental regulation of umbilical vessel flow with extrauterine pressure variations. The sheep gravid uterus has served as an animal model of placentation, fetal development, and pregnancy for decades, supporting the decision to use it as a model for hemodynamics and perfusion. We chose to study the sheep fetus at a periviable period, the equivalent of 22 to 26 weeks of human gestation, or 110 to 115 days of sheep gestation. An ex vivo placental perfusion model was employed with a low transverse laparotomy on a gravid ewe and uterine delivery. We used singleton pregnancies for this experiment. We administer rectal indomethacin as a tocolytic prior to incision. The circuit was primed with whole blood obtained from different donor ewes, and blood or crystalloid was administered for volume maintenance. The uterine vessels were isolated and cannulated, facilitating transition to full ECMO support. Because of the cotyledonary nature of the ovine placenta, the placenta cannot be isolated from the uterus, so a full hysterectomy was performed. To maintain adequate flow, there is constant manual titration of pump revolutions per minute, which leads to fluctuations in the pressure by which blood is delivered to the uterus. Specifically, we measure the flow through the uterine artery when it's in its native state prior to cannulation, and then we replicate that flow by pump titration when in the warm saline tank. No prostaglandins were administered. 6 gravid ewes had ultrasound Doppler measurements obtained before laparotomy and after transition to ECMO support to document shunt patency and flow velocities at the DA and umbilical cord vessels. Baseline velocities were compared to velocities on ECMO support with students' paired t-tests. In addition to no statistical difference, velocities remained low, specifically below 2 meters per second, suggesting no flow restrictions and hemodynamically significant PDA. Similarly, umbilical vein peak velocities remained low after transition. There was also no statistical difference in peak average velocity through the ductus before or after ECMO cannulation or umbilical vein peak velocity. While not strictly translational, we plan to use this ovine placental preservation model next to investigate adaptation the placenta provides to changes in the uterine artery flow and the placental production of prostaglandins, among the other listed uses. While perfusing a gravid uterus via the uterine vessels in a short-term model of support, we demonstrate a patent fetal DA and relatively constant umbilical vein flow velocities, despite fluctuations in the ECMO pressure delivery to the uterus. The placenta therefore maintains regulation of umbilical blood flow velocity with pressure variation and facilitates physiologic shunt patency. Thank you, and I'm happy to take any questions.
Questions? I have a quick question for you. Are there medical therapies that you also use to keep the ductus open, or is this just strictly flow?
So in our model, we don't administer medical therapies to keep it open. So there are other models that have the circuits lined with NO or administer prostaglandins, but our model, we do not.
You do not, okay.
Thank you.
Oh, wait, quick question.
Sorry.
Congratulations. It's beautiful work and a very interesting model.
Thank you.
I just wondered if you could expand a little bit on your actual ECMO circuit support. Are you a roller pump or centrifugal? And what oxygenator did you use in the study?
Yes, so we used a model with a pump. We used a roller pump. And then I'm not sure on the specific oxygenator that we use. I'm sorry, I'm happy to get back to you on that. And we're supported by 2 perfusionists during the actual experiment.
Thanks so much. Really nice work.
Thank you.
Thank you. Wait, one more. One more question. We have time.
Olutoye Columbus, something to help me understand. Your premise is that the change in blood flow through the placenta and through the cord is what's mostly responsible for ductal constriction, correct? And so is that what you're trying to maintain by maintaining your ex vivo perfusion? Is that what this is starting? Am I getting that right?
So we started out wondering if if the preservation of the placenta was sufficient to maintain ductal patency. So our premise is that the prostaglandins, as well as the flow regulation through the placenta, maintains the ductal patency. I'm sorry, I'm not sure if I answered your question with that.
No, I get it, because I mean, maybe it's just my very elementary way of thinking about it. So yes, there's that element, but at least one of the reasons we don't ventilate during an exit procedure is ventilation is an important part of actually stimulating that ductal patency. And so how much of that is ventilation related and decrease, pressure within the pulmonary circulation versus just the maintenance of perfusion through the placenta and the cord?
Right, so we don't have ventilation in this model. The fetus isn't exposed to air yet and the lungs aren't exposed to air. And so the maintenance of the ductal patency in our model is independent of air exposure in the lungs.
So conversely, have you therefore in your model been able to show those that actually do constrict in your model?
So we haven't attempted constriction of the ductus in this model yet, but it would be something that's very interesting to look at.
Elegant study then, thanks.
Thank you.
Thank you.
Dr. Danzer from Memorial Sloan Kettering Cancer Center is presenting preliminary efficacy and safety fetal intervention studies in the lower urinary tract obstruction and pleural effusion LAM model, utilizing a novel fetal shunt, the vortex shunt.
All right, thank you very much for the opportunity to present, and thank you very much for your attention. We're going to present on the efficacy and safety of our new developed shunt, the vortex shunt. These are our disclosure. We have a patent, and we have several patent applications pending, so some of the images and the videos you're going to see today are a little bit blurred out because of disclosure issues, and we created a company. Lower urinary tract obstruction or vesicular hemolytic shunting for LUDO has been introduced in the 1980s using the Harrison shunt and the Roddick shunt, and more recently, in particular in Europe, using the Somatex shunt. While these are working, they all have one problem. They have a significant dislodgement rate that has been reported in the range of being 40 to 80%. And with the dislodgement, there are downstream effects. Number one, the treatment is interrupted. The natural history of ludo cannot be reversed. And with the need for additional interventions, there are maternal, fetal, and obstetric complications that will subsequently lead to significant neonatal morbidity and mortality, as well as long-term renal morbidity in those survivors. Based on the clinical need, we developed a new shunt, as shown here, the Vortex shunt, which is made basically out of two materials, polyurethane and nitinol. You have the nitinol braided anchors on each side that are expandable and collapsible as needed, and then you have the polyurethane covered coil conduit that connects those anchors. We did extensive in vitro and benchtop testing, including pull-out force testing, as shown on the graph on the left-hand side, showing that the force to pull out our shunt out of a variety of tissues is between 4 to 12 times higher than the other available shunts. Our shunt is bendable, kink-resistant, and it can extend up to 3 or 4 times its original length without losing its capacity of draining fluid. And this is important while once the bladder that is full in a ludo patient is attached to the abdominal wall, once it's emptied, it goes all the way back into the pelvis. And that's why an extendability is very important. And then we also created a valve inside of the shunt to allow for more normal bladder physiology, bladder emptying, and bladder development. So we initially presented our feasibility studies at the last IFMSS meeting, demonstrating that the shunt can be easily placed under ultrasound guidance in the ludo and pleural effusion animal model with no short-term dislodgement for about 24 hours and no injury to any of the other structures and organs. We're then moving on, and that's what we present today, for the early efficacy and safety studies in these preclinical large animal models. Ludo was created, as previously described, at 75 days of gestation by ligating the urachus and the urethra in male fetuses. And then these fetuses are returned to the uterus, allowed to develop the full phenotype of ludo over the upcoming 2 or 3 weeks. Then we use ultrasound-guided placement of the Vortex shunt, and as you see, our shunt is highly echogenetic and easily visible and traceable when you place it. And then these animals are allowed to continue until term, and they're harvested 6 weeks after shunt placement, around 140 days of gestation. And these are the key images of our results, demonstrating that after the shunt placement, we have resolution of all the key anatomical features that ludo is presented with. The Vortex shunt remained in the appropriate position throughout gestation. We have done so far 17 animals, and all 17 animals had the shunt in place at term. There was no dislodgement, and there was minimal to no internal or external incorporation. And I highlighted on the open displayed bladder on the bottom image with a forceps the entrance point of the shunt to the bladder. There is some minimal mucosal hyperemia, but no real mucosal injury. We also looked at patency of the shunt at the end, as some of the other available shunts get clogged and need to be replaced for that one. And you see the shunt is patent throughout gestation. And then the other video showed our developed retrieval mechanism. So the shunt is easily retrievable at bedside after the sheep, and hopefully at some point the fetus is born as well. Looking at some of the key parameters of the outcome, and for easy orientation, the control fetuses are depicted in the black graph. The ludo Vortex fetuses, the fetuses that got shunted, are depicted in the white bar graph, and the ludo only, the non-shunted fetuses, are depicted in the gray graph. And as you can see, after ludo shunt placement, the deepest vertical pocket normalizes, meaning the amniotic fluid, a key feature of ludo, is improved, the normalization of the amniotic fluid. We have a normal fetal body weight. We have a normalization of the bladder to body weight ratio, as well as a normalization of the pelvic diameter on the left and right kidney at term on ultrasound. And these are the representative ultrasound and macroscopic kidney images, and as you can see, in the ludo only, in the non-shunted group, there are significant hydronephrosis, completely destroying the renal parenchyma, which we know in term in human fetuses on human babies leads to end-stage renal failure. And when you look at the shunted fetuses, their renal parenchyma, their cortex and medulla is greatly preserved. And we looked at severity of hydronephrosis based on prenatal ultrasound standard guidelines. We show that after the shunt placement, again depicted in white bars, the majority of fetuses had no evidence of hydronephrosis, and a few had some moderate hydronephrosis. But when you look at the gray bars, the majority of the non-shunted Ludo patients or fetuses had significant severe hydronephrosis, and those with mild hydronephrosis are actually those their phenotype was so bad that they either ruptured their bladder or the urachus and emptied the urine through the perforation. We also did some initial contractility pattern studies on the fetal bladders using a standardized setup, as we have previously published, using electric field stimulation, KCL, and kappa call exposure. And these are the results for the kappa call dose escalating curves, the KCL escalating curves, and the electric field stimulation on the far right hand. And when you quickly look at these dose escalating curves, you see two features. Number one, the ludo-shunted fetuses, their bladder contracts very similar to the normal fetuses, and it appears that there is no difference to the non-shunted bladders. However, the standard deviation, so the phenotype of the bladders in those ludo animals that haven't been shunted is very wide. That's why the standard deviation is wide. And when we did a subgroup analysis by excluding fetuses that had a perforation, you can see that the non-shunted Ludo patients depicted in the purple line had significant less contractility response than the Ludo-shunted and the non-shunted patients. We also looked at the pleural effusion, as shunt placement is commonly used in fetal pleural effusion or fetal lung lesions. And as you can see, there is no real chronic lung, no chronic model for pleural effusion. So we create pleural effusion by instilling about 50 cc's of Hartmann solution into the fetal chest, as you can see in those videos. And then the shunt is rightfully placed at the same time. Of course, the pleural effusion is immediately drained, but it's very similar to the Ludo animals. In the fetal pleural effusion animals, the shunt remained in place for 6 weeks. We did 7 sheep so far. We cannot assess the efficacy of the shunt in reversing pulmonary hypoplasia because these animals don't have pulmonary hypoplasia to begin with. But what we did assess is the safety, meaning a lot of fetal chest shunts their fetuses will develop chest wall deformities and hip deformities, and we use X-rays and 3D CT reconstruction image tools, and we have not shown any rib deformities in our animals. So in summary, our preliminary efficacy and safety are very promising. We showed no short-term dislodgement and no long-term dislodgement over the course of 6 weeks. The vortex shunt remains functional throughout the implantation period. We see a normalization of the hydronephrosis and, at least macroscopically, a normal bladder anatomy and normal renal anatomy in those animals. Our preliminary function testing is very encouraging, and from a safety standpoint, we haven't seen any damage or injury to any of the surrounding structures, no tissue incorporation, no omental, or even worse, no intestine wrapping around the shunt in the abdomen. The histopathological assessment is forthcoming, and I'm hopefully I'll be able to present it at some point in the future. The incorporation of the valve in itself will hopefully augment bladder development and bladder contractility in the future as well. I'm very happy that we're working with the FDA and that our GLP studies are currently underway, and our first GLP animals will be shunted on Monday. Thank you very much for your attention, and I'm happy to answer any questions.
One question.
Elegant study, Ronnie Marwan, Mizzou. Have you done any flow dynamics through either the shunt or the valve? Because sometimes it's not just the size, but as you know, the back pressure on the developing kidneys is part of the problem in fetal renal failure.
Yeah, so we have these studies done in vitro testing, but not in the animal setting. It is part of the agreement we have with the FDA. And whoever has done device development and brought trials through the FDA to the market, it is a stepwise approach. And right now we're focusing on the primary aim of no dislodgement, which is important for pleural effusion and for Ludo. And you don't need a shunt, you don't need a valve for the pleural effusion. So we are working in vitro and benchtop testing. The valve works very nicely, and hopefully we can present it at some point. But eventually, you're absolutely right, these will be part of additional studies in the future.
Your lack of dislodgement rates are really impressive. Have you removed any in alive animals?
Yeah.
Yeah.
Yeah, and that's with the retrieval mechanism. So there, as I said, there's no incorporation with, that's one of the things, that's why this video was priority, because that's part of the new patent application. It's a device that we developed to easily retrieve it, and it takes no pull force, no pressure. It's very easily retrievable.
Very cool. Thank you.
Thank you.
Our last presentation of this session is by Kira Halbert Elliott, who's a medical student at Johns Hopkins. We'll be speaking on contemporary use of maternal betamethasone in the treatment of fetal lung malformations, results from a national multi-center cohort study.
Thank you. Hopefully next year I'll be able to come back and say Dr. Halbert Elliott. Okay, I'm excited to be presenting the second set of results from the congenital lung malformation study group today. Okay, so why did we do this? We really wanted to know how is betamethasone being used across care centers nationwide. And we also wanted to know what are the outcomes for fetuses treated with betamethasone, all to help develop evidence-based guidelines for betamethasone use in the future. Since their introduction in the early 2000s, steroids have become a mainstay of use for large congenital lung lesions, whether identified by lesion size with CVR or the presence of hydrops. Early studies showed the most efficacy in microcystic CPAMs, particularly when betamethasone is administered before 27 weeks of gestation. Anecdotally, though, we know that steroid use has expanded beyond this initial population to macrocystic CPAMs, bronchopulmonary sequestrations, and small lesions with presence of hydrops. However, the evidence supporting this use is mixed at best, and most studies are small, single-center, limited by the relative rarity of congenital lung malformations. So we started to wonder, how exactly is betamethasone being used when we have these anecdotes? And what are the outcomes of patients who receive betamethasone, whether compared to non-recipients or even in different subtypes? And as my build-up probably hinted at, the aim of this study was to elucidate the use and impact of maternal betamethasone administration in the management of lung lesions at fetal care centers nationwide. This was a retrospective multi-center study formed from the newly formed Congenital Lung Malformation Study Group, which is a consortium of 17 care centers across the nation. For the purposes of this study, we queried patients diagnosed with a CLM between 2016 and 2023, totaling 1,536 patients. These numbers are updated from the abstract we submitted in the fall, and we also are excited that this is the largest study done of congenital lung malformations to date. We excluded patients diagnosed postnatally or with unavailable neonatal records, and to isolate the effects of betamethasone administration just for lung lesions, we excluded those who received steroids for prematurity, giving us 1,216 patients. When looking at the demographics, we found that 25% of patients received betamethasone for lung lesions. Betamethasone recipients were far more likely to have evidence of mediastinal shift, not surprising given their large size, or evidence of hydrops, with 11% showing hydrops on ultrasound scans. Betamethasone recipients were also far more likely to have CPAMs, but we also noted that several bronchogenic cysts, sequestrations, and other lesion types received steroids as well. When looking at the indications for betamethasone, we found that far and away the most common reason was large lesion, followed by other, and finally 10% for hydrops. We also found that 17% of betamethasone recipients received multiple courses, with several receiving courses every week until delivery. To better look at the effects of betamethasone on the clinical course of these lung lesions, we looked at CVR across gestation. Unfortunately, we did find that CVR was much higher in fetal betamethasone recipients, both at minimum, maximum, initial, and final, and across gestation at different time points. As I mentioned earlier, the evidence for use in macrocystic CPAMs has been mixed, and we decided to take advantage of our large cohort to look at the outcomes of betamethasone recipients as stratified by their macrocystic or microcystic CPAM diagnosis. What we found was that macrocystic CPAMs had higher CVRs across gestation and also had higher maximum initial and final CVRs when compared to microcystic CPAMs. When looking at the clinical outcomes further, we found that betamethasone recipients still had higher rates of clinical morbidity, including higher rates of ventilator requirements and neonatal surgery, with 31% requiring surgery in the first 30 days of life. When looking at the outcomes of betamethasone recipients specifically by lesion type, we found that macrocystic betamethasone recipients had higher final CVRs than microcystic, with 1.45 being macrocystic compared to 0.9 in microcystic. This is despite having a far higher rate of fetal operations, with 34% of macrocystic receiving a fetal operation. The most common type was a thoracoamniotic shunt, followed by a thoracentesis. When looking further at the outcomes of betamethasone recipients by CPAM type, we found that despite having similar gestational ages at birth, macrocystic CPAMs were far more likely to require neonatal surgery, with 55% of macrocystic lesions requiring surgery compared to just 15% of microcystic. In conclusion, we found that 25% of patients receive betamethasone, primarily guided by lesion size as identified by CVR. We also found that betamethasone administration may have a greater effect in microcystic lesions as compared to macrocystic. We also found that macrocystic betamethasone recipients often required more invasive fetal interventions and had higher rates of neonatal surgery. As you might expect, we do believe that further analysis is warranted to develop evidence-based guidelines for betamethasone administration. And to that point, I would like to once again invite anyone who is not yet a member of the Congenital Lung Malformation Study Group to consider joining. We have the QR code above for anyone to scan, and if you would like to talk to myself, Dr. Sisklefer, or Dr. Kunisaki, we would be happy to answer any further questions you may have. Thank you for your attention.
Nicely presented. Questions?
Hi, Shin Hiroshi, Seattle Children's. That was a great presentation. Thanks for doing that. I was curious if you knew the median or mean number of doses that you had in the group, because you said sort of offhandedly that someone was giving weekly betamethasone. I can tell you, so my wife's an MFM, and she'd hit me over the head with a stick if I suggested that.
I actually don't know the median off the top of my head. I just remember looking through the data and seeing several that had been noted to receive weekly injections, but we can definitely look into that for the future work. Thank you.
Dimitra Latakis, Indiana University, Riley. So my question is a lot of the research that we do is important for clinical care and our clinical application and treatment, but how do you think these results affect your prenatal counseling of moms that we're giving steroids to and what that might imply for postnatal care? Is that going to change how we counsel them based on what we're seeing in this data?
I think it's hard to make massive changes to clinical counseling at the point where we only have a retrospective review, but it is interesting, at least to me, as a hopefully future pediatric surgeon, to think that we may be giving something that may not be working as well, and we should do more research so that we can counsel moms whether or not this treatment is an option that will help the future outcomes.
First of all, excellently presented. I think you did a fantastic job with that presentation. Really great work.
Thank you.
As you go along with this, one important aspect that would be nice to have in your data is echo findings. Now, one of the considerations, the whole switch about whether steroid works or not is because we're now allowed to wait and actually see what happens. And miraculously, many of them get better after 27, 28 weeks. But that was always the natural history of these long lesions anyway. Was it steroids? Was it not? It's difficult to tell without actually telling, because we know there's some fetuses that have high drops, in which case they have pleural effusion, they have ascites, but with excellent cardiac function. So those ones don't have heart failure. And if you actually wait those out, they'll get better whether you give steroids or not. So I think the jury is still out whether steroids are making the difference, but so easy to give, people are giving it every week. You know, it's going to be hard to go back and put that genie back in the box and and do a study because it's so easy to give steroids. Now, I'm sure if you talk to the neonatologists and neurologists, steroids are not without their own effect. Yes, we give it all the time, but there are probably long-term consequences of it, so it shouldn't be given, and definitely shouldn't be given all the way to term, because there's no evidence that you even need it after 27, 28 weeks. But as you collect your data prospectively, I think collecting that cardiac functional information will be helpful to actually see whether we're making a difference, and that those who are doing okay are those that are not. Because people give the third, fourth dose, it's like, oh, that fourth dose made the difference. Well, incidentally, that fetus was also 28 weeks at that point. So was it the steroids or was it not? But excellent study. I think the collaborative should be able to help answer some of those questions.
Thank you. Yeah, the hope is to eventually compare against large lesions that did not receive steroids. But thank you for your points.
Great. Thank you to all our presenters for doing such a wonderful job this afternoon. Please stop by and thank our vendors for their support of the conference and check out their offerings. You now have some free time, and then we invite everyone to attend the welcome reception from 7 to 9 at Agora Centre-Ville. Thank you.